Welcome to the American Heart Association Statements and Guidelines podcast, where we'll discuss clinical practice guidelines and scientific statements on various cardiovascular disease and stroke topics.
Welcome to the Prevent Calculator for Primary Care Education, brought to you by the American Heart Association. In today's episode, we dive into the groundbreaking Prevent Risk Calculator, a powerful tool designed for healthcare clinicians and their patients to assess risk of cardiovascular disease. But first, let's set the stage. Cardiovascular health isn't just about the heart. It's a complex interplay between the heart, kidneys, and metabolism. The American Heart Association's Cardiovascular Kidney Metabolic, or CKM Scientific Advisory Group, developed the PREVENT equations, which estimate 10-year and 30-year risk for cardiovascular disease. Let's listen in.
Hello, I'm Dr. Howard Haft. I'm delighted to be here today with Dr. Sadiya Khan to discuss the Prevent Risk Calculator. Dr. Khan, thank you so much for joining me.
Thank you so much for chatting with me today. I'm excited to start this conversation with you.
Dr. Khan, this calculator really fits well into what we know now about the CKM syndrome. Can you discuss CKM a little bit for our listeners?
Yeah, and part of what really led to the calculator was starting with the CKM syndrome itself. The cardiovascular kidney metabolic syndrome was defined by the American Heart Association last year as really this clustering of conditions and health disorder that occurs due to connections between heart disease and kidney disease, diabetes, and obesity that together lead to poor health outcomes. And one of the things that is really helpful within the CKM or cardiovascular kidney metabolic definition are these stages that help outline where somebody is along that spectrum of health and disease. And within that, as we were talking about this, we thought about, well, this is really helpful qualitatively. The stages give us an idea of whether or not somebody has progressed to have diabetes or hypertension. But we know a lot of people live in this primary prevention space where they don't yet have heart disease, but may be at risk for it. And that led us to these questions of, well, how do we best characterize risk? And really where the conversations for Prevent started, where within this context of, we know that cardiovascular disease is changing today, and there is this emergence of the CKM syndrome, and how do we best characterize risk quantitatively within that framework as well.
As the chairperson of the writing group that was responsible for bringing us the Prevent Calculator, can you tell us a little bit about how it was developed?
I think one of the things that we were tasked with is it's been about 10 years since the last calculator was developed and published, the pooled cohort equations, which we're all very familiar with and use every day. And one of the things that we were thinking about, a lot has changed in those 10 years, both from a positive standpoint with a lot of opportunities for prevention and new therapies that are now available to us and our patients. But unfortunately, there's also been a lot of change in terms of the types of risk factors that are now present, with growing risks for obesity, more diabetes that's present in the population, and changes in terms of what types of disease are present, like the emergence of heart failure more than atherosclerotic cardiovascular disease like heart attack and stroke, which was the focus of the prior calculator. So those are a few things that were bubbling to the surface and really prompted us to say we need a new, more accurate model for today's patients.
No, certainly things have been changing, and our population is changing, and these old calculations that we had grow a little cold over time. So tell us a little bit about how you actually went about implementing, looking for those right factors and implementing them to make sure you get the calculations and the risk equations as close as you can to representative.
Yeah, that's a great question. And it's definitely one we spent a lot of time on, is how do we most accurately predict risk? And that, like you said, means that we have to pick the right things to use to predict risk. One of the principles that was the most pressing for us was to ensure that we use markers that were readily available in primary care settings, that were already available to clinicians. There may be great utility of some newer biomarkers that exist, But if we're not already measuring them, if that's not already part of our workflow, it's going to be challenging to have a model that requires a new biomarker. So with that in mind, we wanted to think about what are the risk factors that still are relevant. So all the things that we still know in terms of blood pressure and cholesterol and smoking history and diabetes, and what are the new ones that we want to consider. And here there were two new ones that we thought were really important. One being kidney function with eGFR, and the second being use of statin therapy. While the prior calculator was really developed to say who should be on statin therapy, who should be on this lipid-lowering therapy, we know that many people are already on statin therapy and appropriately on lipid-lowering therapy, and we didn't want this model just to be relevant for people who are not yet on therapy.
Yeah, I think that makes great sense also. As I looked at the calculator, there are also a lot of other innovative pieces to the to things that are there. Some that are optional parts of the calculator and some that are standard parts. Can you speak a bit to those things that are really innovative in the calculator?
Yeah, that's a great question, and one that we spent a lot of time thinking about. How do we make this a true advance forward in how we think about risk? So we mentioned one of them earlier was incorporating in heart failure risk. So making sure that we were really capturing total risk for cardiovascular disease and not missing this piece that comes from the risk for heart failure as well. We thought a lot about how do we do this optional component as well as standard component, so that for those where it's indicated, particularly for people with kidney disease, with diabetes, with hypertension, or who qualify for screening for diabetes, the measures of hemoglobin A1C and UACR, when available and indicated, could also be used to help personalize risk estimation. A third thing that we focused on was being able to estimate risk for the short term in that 10-year horizon, but also the long term in the 30-year horizon. And one of the things that was really complementary with that was expanding the age range for which the calculator could be utilized to adults 30 to 79 instead of where pooled cohorts was starting at 40. Part of the reason for that was so that we could really capture this risk that is emerging earlier and earlier in life, so that young adults aren't left out of the conversation of prevention, perhaps when some of the yield might be the greatest if we're able to initiate some of our prevention strategies. But we also realize that just having short-term risk is probably not going to be helpful for a young person. So we could put younger people in the model and have a risk calculated for a 30-year-old, but most 30-year-olds are not going to have a heart attack, stroke, or heart failure in the next 10 years, even if they have a lot of risk factors. But really what we want to predict is not risk over the next 10 years, but over the long term and over the 30 years. So those are a couple of the things. There were some other changes in terms of how we considered race in the model, how we incorporated social determinants of health with a zip code level indicator, and making sure that we used the most generalizable sample available to us from EMR data and observational cohort data.
So a much broader pool of information to draw from. The more information you have, the sharper the tool is in terms of predicting future events. In a much longer horizon, starting much earlier in the life cycle, where prevention can actually have a much longer run at preventing those diseases that we know start very early, but sometimes are not recognized till much later. That's wonderful improvements over where we were before. Dr. Khan, I noted that you used zip codes in one of the optional parts of the calculator. I assume that's zip codes are a surrogate for area deprivation index, but you steered away from race specifically.
Yeah, it's a really important question, and one that we spent a lot of time discussing. How do we best capture risk most accurately and precisely, and do that well for everyone, and do it well across populations, both individuals who identify as white, who identify as Black, who identify as Asian? And in order to do that, I think the point you hit on before is really critical, making sure that the data that we use to develop the model are as inclusive and generalizable as possible. So I think one of the things that really helped us be able to do this well was having data available from over 3 million US adults that included contemporary risk factor data in the last 20 years and able to follow people for events over that time frame. In terms of social determinants of health, I think we have seen really a growing emergence of research that identifies that racial and ethnic disparities in the United States are pervasive, enduring, and unacceptable. They continue to be present where Black Americans die from cardiovascular disease at a much higher rate than white Americans. And part of what we understand about the reason for these disparities are the differences in these underlying social determinants of health. While zip code level social deprivation index is one way to capture risk based on where someone lives, it's really an early step. It's a first step forward that helps to identify and personalize risk based on one measure, but it's insufficient. We know there are so many other factors that are relevant and important. And I think one of the things that we want to work on as we move forward is how do we best incorporate those?
I think that's very well said. And as you look forward now to what the next iterations or the refinements on Prevent will be as we look, even as we launch this exciting tool now, what do you think the next steps will be, and where are the places we'll have to lean in to get even more information and be more specific?
Yeah, I think we're in a wonderful era where contemporary data in real time are available and accessible. The concept of big data and having the ability to utilize and leverage electronic medical record data is quite exciting, and I think gives us the potential to consider Prevent as a bit of a living model. Can we update, refine, and continue to test, calibrate, and reassure that we are doing a good job equitably predicting risk? I think the other piece of the equation that perhaps is an even bigger piece of the equation from the consideration of health equity is not just does the model perform well, but we know a large part of what leads to inequities are the downstream implementation. Is the model being utilized in all populations? Is there healthcare access? Is there equitable access to evidence-based therapies? And so I think this is a launching point to really help us say, how do we move the needle on health equity for cardiovascular disease prevention more broadly?
Yeah, I agree completely. And I think it has everything to do with, as you said, with implementing this tool into the everyday practice of primary care and other places, perhaps population health managers and others. But the sweet spot really is primary care, a place where people join early, they have longitudinal care, and being able to, at the earliest stage, to be able to identify risk factors and see how they change over time and be able to modify those risk factors. You know, the challenge is going to be how to implement that in workflows. It's a great tool. There's no question about that. But any great tool, if it just sits on the shelf, is just another shiny object. I think really what we need to make sure is that this tool gets implemented into the workflows of as many primary care practices and preventive cardiologists and others who really can use this tool to help educate their patients and be able to make those critical pieces of information aware to people where it makes, at the time and in the place where it makes a difference. You know, one of those challenges is getting our colleagues who have the electronic medical record companies to open their doors and say, yes, this is something we want to implement in context as we're seeing patients with the applicable data already loaded into the tool. I mean, that is, in my mind, that's healthcare nirvana. That's where we really can make a big difference and do it in an efficient way.
Yeah, that seems like a really important point that you made in terms of the barriers to implementation. What are some of the other things that you think need to happen so that we can have rapid uptake. We know there's always a lag when there's new evidence, when there's new models, and some of that are challenges like you mentioned in terms of electronic medical records. What are the other gaps and how do we address them so we can really move forward more quickly than we have before?
So I think the biggest gap really is how busy providers are, how little time they get to spend with patients. And right now it's a matter of being as efficient as you possibly can in getting the right information to the right person at the right time. And I think we've come to understand that the best way to do that in our current context, with how we record healthcare information in electronic medical records, is to have that information at your fingertips in front of you and the patient at the same time. And that's a wonderful teaching moment when you can actually sit with a patient and say, this is you, here is where you live, here is your medical background, here is your social profile, here are your habits, and here's what your risk looks like for the next 30 years. But if let's start manipulating this, and if we see that your BMI is lower, and if your sugar control is improved, and if your kidney function is fine, your risk is so much less. And it's also a good place to, have this conversation with patients about, what else do you need to support you socially? This zip code issue here really says, perhaps you don't have the transportation or the food or the other supports that you might need in your life. And, what are the things that we as healthcare providers either can do directly or advocate for? It is so important to have those crucial conversations with really credible information right in front of you and the patient at the same time.
And you made a really important point that we are constrained by time. And so one of the other challenges, especially for primary care clinicians, is that you're balancing so many different things and doing so in a very compressed time frame that you have with the patient.
Yeah, but that is the way it is right now. I think we have to accept that. And for that reason, tools like this become so critically important. When you have such precious little time to spend with patients, it is so wonderful and so important and so effective to have really, well documented, strong information that you can add to a conversation that's supported by a long-term relationship with a patient. Those things together really can alter the way people live their lives in a positive way.
And the exciting thing is we have a lot of therapies at our disposal that really can do that if we can identify the right patients to target with those therapies and be able to manage some of the challenges related to cost. Because I think that's probably another big barrier that we really need to overcome.
Yeah, absolutely. Now, of course, the cost for this kind of tool is de minimis compared to the cost for those medications that are produced by pharma, particularly the new medications, and while they're still under patent protection, are quite expensive, but very valuable at the same time. So last, let me just ask you, was there anything really in this process that really surprised you? Things that when you started on the journey to build Prevent, you never suspected that this or that was going to be important or show you the results that it showed you?
Yeah, that's a great question. I think there were lots of interesting insights along the way. Being able to incorporate kidney function was a really important aspect of that. I think the surprise to me around some of the additional variables was, again, an implementation gap of how frequently they're available. And I hope that part of the platform from the Prevent model with the add-on for UACR and hemoglobin A1C also helps nudge to ensure that we are screening all individuals who qualify for screening. For example, for UACR, we know that there's very limited uptake of appropriate screening to assess for kidney disease, especially among people with diabetes, where that can be a very helpful tool for monitoring and for guiding therapy now that we have wonderful therapies that are useful for patients with diabetes and albuminuria. And so I think that to me was not something that I was necessarily thinking about from a risk prediction framework, but is very useful, we hope, from an implementation framework.
Dr. Khan, thank you so much for this very insightful conversation. I look forward to learning more from you in the future.
Thank you so much, Dr. Haft. This has been a really fun discussion, and look forward to seeing this hopefully help improve people's health and reduce risk for heart disease.
Thank you all for listening in today. For any questions or concerns regarding the use, functionality, or the risks estimated with the Prevent Calculator, please email prevent@hart.org.
The data and statistics presented in this podcast are from the official guideline being released by the American Heart Association. Any and all personal stories and testimonies are that of the talent, host, and volunteers, and are not reflective of any statements or position of the American Heart Association. For a full manuscript of the guideline released, please visit the official American Heart Association website at professional.heart.org.